Hello, welcome everybody as you're joining. We are operating on UCSF standard time, which means most things start about 5 minutes after. So we will get started in just about 1 minute. Okay, great. Well, welcome everybody. It's 12:05, so we'll go ahead and kick things off to be mindful of everybody's busy schedules. I'll start us off. My name is Veronica Masharikova. I'm an assistant professor in the Division of Adolescent and Young Adult Medicine at UCSF, where we have recently started the UCSF Youth Outpatient Substance Use Program, of which I am the medical director. And I'm very excited to be expanding on youth addiction services in the Bay Area. So just a few housekeeping announcements. Please, if you're not speaking or asking a question, if you could be sure to mute yourself so we don't have any audio feedback. And while we are speaking, please feel free to use the chat function to ask questions. And Michelle Shore, who is on and is our education analyst for our project, will be keeping an eye on the chat and making sure that your questions can get answered in a timely manner. Of course, we will also make ourselves available by email for any outstanding questions that may arise. So let's get started. So we're going to today focus on buprenorphine, and I'm going to start with a case presentation that inspired this symposium. We'll then kick it off to Dr. Sharon Levy from Boston Children's Hospital, who's going to talk about the opioid epidemic and youth at large. Leslie Green, who is a social worker at Boston Children's, will then interview a parent of a former patient at the Boston Children's ASAP program, their substance use treatment program. We'll then cover some legal questions and answers with Dr. Brian Hurley. There are many questions that arise around how to administer buprenorphine in various treatment settings, and he can provide that expertise. Then we'll kick it off to Dr. Emily Tajani, who's a child and adolescent psychiatrist and also an addiction psychiatrist who consults at the UCSF Youth Outpatient Substance Use Program. And she will talk about youth who have opioid use disorder and other co-occurring psychiatric disorders. And then we'll get a little bit into how to get started with buprenorphine prescribing. So let's kick it off. Our learning objectives are posted here for your reference. I won't read them out loud so we can get going. Next slide. So I'd like to start with a case, and this case is really what inspired a lot of what we're doing today. Next slide. So in 2018, there was a 15-year-old boy who was found unresponsive at home by his mother. Mom appropriately called 911 and was instructed to start chest compressions for this young man. When EMS arrived, they found him with shallow breathing, a very low oxygen saturation, and pinpoint pupils. They astutely provided him naloxone, which is the opioid antidote, and he immediately responded and woke up. He then was brought to the emergency department. In the ER, he did report using cannabis, cocaine, a history of using prescription opioids that he got from his parents, and a history of prior injection drug use at age 13. When they did his urine toxicology screen, the screen was negative for opiates. And so therefore there was a concern about a synthetic opioid overdose, since many of the synthetic opioids do not show up on routine screening tests. And this was the final assessment from that ER visit. You can see, I pulled a direct quote from the medical record. Patient does not see his behavior as addiction or in need of referrals for treatment programs. And he was discharged home. There was no prescription for naloxone. There was no referral to addiction treatment. And I would say this presentation of adolescents underestimating the severity of their substance use is quite common. Next slide. So looking at the epidemiology
Small coffee.
of opioid use disorder among young people, there is some good news in that it seems like opioid use disorder has been on the decline over the last several years. One other thing that I'd like to point out on this graphic is that the age group that's most commonly struggling with opioid use disorder are the young adults aged 18 to 25. So in my practice in adolescent medicine, I treat patients aged 12 up until they turn 26. So I think that's notable that, okay, maybe adolescents have fairly low rates, but something happens between 17 and 18, and we need to be paying attention to this. Next slide. Now, while opioid use disorder rates seem to be declining, the unfortunate reality is that drug overdose death rates are continuing to increase. Next. And again, I'm pointing out that 15 to 24 age group. Now, subsequent years, this is newer data from 2017, 2018, did start to show a bit of a decline in drug overdose rates. Next. But not everywhere. So as you can see, the states that are highlighted in this dark blue still had statistically higher drug overdose deaths in 2018 compared to 2017. And for us in California, this is important. Next. And just like what we saw with our young man in the case, there was a lot of concern for synthetic opioids. And that's what we're seeing as a major contributor to drug overdose death rates over recent years. The synthetic opioids like fentanyl and carfentanil have been implicated in many of these deaths. And unfortunately, many of the drug supplies are highly contaminated with these synthetic opioids. And I've seen numerously patients who thought they were using cocaine or thought they were using, Xanax that they bought on the street and ended up having an opioid overdose because their drugs were contaminated with fentanyl. Next slide. So let's take a look at what happens in regards to treatment after opioid overdose. There was a retrospective cohort study done by Avik Chatterjee and his colleagues. Next. And they looked at people treated for non-fatal opioid overdose in Massachusetts between 2012 and 2014. This was a large cohort, over 20,000 people. Fortunately, only 195 were within the adolescent age group, but still that's too many. And what they found is that fewer than 5% of adolescents were receiving medication treatment for opioid use disorder prior to their overdose. So this leads us to believe that either their substance use problem wasn't identified, or if it was, they weren't receiving life-saving treatment. And even after they came to the emergency department with a non-fatal opioid overdose, only 8% of adolescents received medication for treatment of opioid use disorder in the year after the overdose. And this is compared to 29% of adults. So there are huge missed opportunities for adolescents who come in for care after an opioid overdose. So why use medication for treatment of opioid use disorder? So number one, and I think most importantly, is medication treatment for opioid use disorder saves lives. Next, it increases retention and treatment. It decreases illicit opioid use and other criminal activity among people with substance use disorders. It allows patients to get back to life, to maintain employment. And it improves birth outcomes among women who have substance use disorders and are pregnant. And again, I really want to emphasize that medication treatment for opioid use disorder is a life-saving treatment. So this is a study from Annals of Internal Medicine looking at survival rates for people who were treated with either methadone, buprenorphine, or naltrexone, which are the 3 FDA-approved medications for treatment of opioid use disorder. And you can see, let me with pointer here, so here especially, the solid line is people who did not receive medication treatment for their opioid use disorder and all-cause mortality. And you can see how the dotted lines here are people who did receive treatment. You can see that their survival was much, much, much improved. So these treatments save lives. Next slide. So what's the deal with detection and treatment of substance use disorders in youth? The sad reality is that they continue to be quite underdiagnosed. So only less than half of pediatricians routinely screen adolescents for substance use, and few are using a validated screening tool. And even when they do screen, pediatricians tend to underestimate the severity of adolescent substance use. One study revealed that less than 5% of patients with problematic substance use were correctly identified. And again, remember our case where the child himself said, I don't see this as a problem. And I see this over and over again. The adolescent really doesn't recognize how problematic their use is, and that may influence what their provider may see as well. And even those who are identified as having problem substance use, up to 20% of those patients receive no intervention whatsoever. Next. And this is a table from a study looking at our youth who are identified as having substance use disorders, are they getting treatment? And as you can see, this looks at treatment for alcohol use problems, illicit drugs, and also for those youth who have both. And what we're seeing is that 90 to 95% of youth with a substance use disorder, this is a diagnosed disorder, not just experimentation, 90 to 95% receive no treatment whatsoever. So let's get back to our case. This is a year later, so 2019. Our patient is now 16. And again, he presented to the ER because of altered mental status. He did endorse using cannabis and heroin that day. And this time his urine toxicology screen was positive for opiates, cocaine, amphetamine, and THC. The patient was admitted to inpatient pediatric service and started on buprenorphine for opioid withdrawal. And this was really an interesting case because I was on vacation for the winter holidays, and I got a call at midnight about this kid and how to start him on buprenorphine, but I was so glad that they called. And he was discharged with a prescription for naloxone, again, that opioid overdose reversal agent, and referred to our program, the Youth Outpatient Substance Use Program. So yay, he got buprenorphine for his opioid withdrawal. He was sent home with naloxone to help reverse opioid overdose. This was a really satisfying outcome. So he enrolled in our outpatient substance use program, and we continued his buprenorphine naloxone prescription. 2 months into treatment, his urine toxicology tests remained free of opioids, but he did continue to frequently use illicit stimulants, unfortunately, and was having a lot of trouble staying in school and getting along with his family. So we did recommend a higher level of care at that point. And here's where this symposium came from. It took us 5 months to place this young man because most adolescent programs denied enrolling him solely because of the fact that he was receiving treatment with buprenorphine. So this is how that felt. It felt like at every turn there were barriers for this young man getting appropriate treatment. And in the meantime, he really suffered. So we're going to get into this. Really kind of inspired me to provide more education to people about youth substance use. So I will kick it off to Dr. Sharon Levy, who's going to take a deeper dive into the opioid epidemic and youth.
Can everybody hear me? Okay, terrific. I want to thank you for inviting me to talk to this group about one of my favorite topics, which is getting substance use treatment for adolescents. And I actually just want to thank you for that wonderful talk. It was really such a great opening. Now I'm going to ask to pull everybody up about a mile high off the surface of the earth, and let's look down on this and try and figure out how we got here. Next slide. So I'm showing you a little timeline of opioid epidemics throughout this country's history. They're actually nothing new. There were probably epidemics as early as the 1700s, shortly after Europeans arrived to America. There was a big epidemic in the 1860s around the time of the Civil War. Almost all of these epidemics, if not all of them, had actually two issues. One was there was a new medication, and the other is there's often a new technology to go along with it. So in the Civil War, the new medication, well, morphine was available, but what the new technology was that the hypodermic needle was becoming available. There actually were not good hypodermic needles back then. So surgeons would actually have to make a small slit in a patient's skin in order to inject medication intradermally. But still, when it comes to pain relief and battlefield wounds, the ability to inject morphine, even with these rather drastic procedures, was remarkable. And so it really made a difference in how soldiers were treated. But then it began the bleeding of morphine use out to civilian populations as well. And we saw this tremendous spike in not only use of morphine and opium, but also resulting addiction. And things actually got so bad that Congress passed what's known as the Harrison Drug Act in 1914, which essentially made it illegal for physicians to prescribe opiates whatsoever. And that actually worked. The epidemic, things were quiet for 50 or 60 years until the Vietnam War, when soldiers were sent off to Vietnam. There was lots of access to opium, poppy flowers. There was lots of trauma and stress, all of which sort of sowing the seeds of another epidemic. At the same time, there was countercultural movement that drug use in the United States, and to combine a heroin epidemic in the 1970s. Now, interestingly, the Nixon administration was the first to introduce the concept of medical treatment for opioid addiction. Now, you know that sounds surprising, but it's true. They were worried about bringing home all of these soldiers and war heroes who might have heroin addiction back into a civilian population, and what would happen. And so really struggling to figure out what to do. And they decided to allow this new medication, methadone, which had been developed largely at the Rockefeller Institute in New York, to be used as a medication. Now, that required some changes in laws because of the Harrison Drug Act, which prohibiting people from using opiates. So the pendulum swung a little bit, and a decision was made at that time that that we would allow methadone treatment, but we would keep it as we would build a parallel system for substance use disorder treatment. And so unlike every other medical condition, which is really typically treated under one roof in a medical center like UCSF, opioid use disorder would be treated differently. We would build buses, we would build clinics, we would build separate facilities just to treat this one condition. Actually, despite all of the problems, I think, in building two parallel systems, methadone actually works quite well. Things again got quiet, and until the late 1990s, and then we have this technology that these new oral opioid medications come on the market, and they're pretty easy to use. They can be prescribed. You don't have to use them intravenously. They're actually a big revelation when it comes to pain treatment. And at the same time, the Institute of Medicine says, hey, we're not treating pain well enough. These two things together, I think people know this history, kind of conspire to ignite the next opioid epidemic. And if you could show the next slide, please. And so, you know, what happens is well-worn history at this point. There's this tremendous increase opioid prescribing. This ends, you know, 7-8 years ago, looking at the period from 1991 2013, where we just see this tremendous increase in prescribing, and creates a unique situation that we had really not seen in previous opioid epidemics. Next slide. In that it creates this tremendous opioid reservoir. Right now, almost any medication cabinet, any medicine cabinet in anybody's home in the United States is probably got an old bottle of opioid around. And this really is absolute fodder for the epidemic to spread down to youth. Because now there's this resource that they can get at. And surveys have found that nearly 85% of opioids, non-medical opioid use by adolescents, is coming out of those medicine cabinets. So the reservoir is really, really problematic. Next slide. And, here you could see rates of opioid, non-medical opioid use or opioid misuse by 12th grade. And you can see there's this tremendous peak somewhere around the mid 2000s, and that's completely the same direction as the opioid prescribing rate. So we know that kids are accessing this reservoir. And then we see a little bit as prescribing starts slowing down, we see non-medical use in the high school age group start slowing down too, right? Because there's less access. More than that, the public health messaging has really changed. So kids start understanding that this is not just something that's easy and fun and harmless, but rather that these are serious and dangerous medications. Next slide. And so why is a reservoir so problematic for teens? Well, the truth is we know that adolescents are interested in and are more likely to be involved in risk-taking, and they're actually developmentally drawn to it, right? In their stage of brain development actually results in them looking for excitement, looking for novelty, and really being a little bit unafraid of consequence. And that's a direct result of their brain maturation. And that's may well be because that was a part of the population that we really needed to be willing to take a chance and do something dramatic, because it's, evolutionarily the part of the population that was strongest and, needed to go and hunt and needed to defend our tribes or our groups from other people. So we wanted, evolutionarily, it might have been very helpful to have this group of young, strong people who would be willing to take chances and do these dramatic things for dramatic gain. But, you fast forward to modern days, and really what it does is it sets them up to use substances, psychoactive substances, if they're available. Next slide. Because all psychoactive substances have this final common pathway in that they are triggering dopamine release in the pleasure and reward center of the brain. And essentially what they're doing is hijacking the brain's natural pleasure and reward system to bind either directly or in a very short pathway indirectly to the part of the brain that releases dopamine. And that is what feels good about it, and that is what causes people to use it. And you can understand that during adolescence, this is more salient than it is even during adulthood. New slide, next slide, I'm sorry. And the other point to remember here is that adolescents don't have, their brains are not fully developed. And some of the higher level structures of their brain, such as the prefrontal cortex, which actually protect the brain from developing changes that are associated with addiction, are not mature yet. And so it's, an analogy here is the building without the roof on top, right? There's nothing there yet to protect the structures that are underneath. Next slide. And we do know that in fact, the age of first non-medical use of prescription drugs is inversely correlated with the risk of developing addiction. And this slide, just that, people who start non-medical opioid use before their 14th birthday, or more than 30% of them will end up with an addiction, even if they're just taking one or two to try it, to see what it's like, or to treat a headache. They're very likely to end up with an addiction. You can see that number falls by more than half if you look at people over age 21. And this is because the brain has a little bit more protection by that time. And if you looked out to 25, you would see those numbers drop even more dramatically as the brain continues to mature. Next slide. Okay, switching gears just for a moment, I want to talk for just a minute about why medication is so important. So this is just a reminder of the difference between opiates and opioids. We heard a little bit about it in the case presentation with the drug test results. There is a difference between opiates, which are naturally occurring or semi-synthetic products like morphine and opium, versus the completely synthetic products that we call opioids, things like hydrocodone, oxycodone, and other pain medications. And there is a chemical difference, and that really plays out mostly in drug testing. Next slide. But in terms of the brain, there's really not much of a difference, because all of these molecules have in common that they can bind the mu-opioid receptors in the central nervous system. Next slide. And this is just a picture. It's a brain schematic that we took from NIDA, and we're pointing to the areas that are particularly rich in opioid receptors. And when we look at where these live in the central nervous system, we can get a sense of what opioids are going to do. Of course, we already know. But if you look at the spinal cord, is very rich in opioid receptors, but functionally these are only available when there's been tissue damage. And so essentially when somebody has pain, these receptors become available, and opioid binding to these receptors is what's responsible for its very dramatic pain relief. But there are other places that opioids bind to. There's the limbic system, which is responsible for the dopamine release and the pleasure associated with use. There's the prefrontal cortex, which of course is responsible for good decision making. So we know that opioid use is going to impact our ability to make good decisions. And then there's the brainstem, and we know that when in overdose, binding in the brainstem results in the lethality of overdose, slowing our respiratory rate and our heart rate. Next slide. So this is a schematic that's just an example of what happens when somebody is using exogenous opioids and binding the opioid receptor, right, with exogenous, like with medications or with illicit drugs. The system actually responds in this schematic. It's responding by growing more receptors, making any single cell that much harder to trigger. Right now, instead of one molecule triggering a cell, we need binding at 3 molecules triggering the cell. And so what happens now is if somebody stops using opioids, can you show the next slide? Somebody stops using opioids, there's something wrong there, because remember that this is a natural system, supposed to have some level of binding and signaling. And when the exogenous opioids are gone and the system is now desensitized a little bit, it really has an impact on how patients feel. And so they typically feel unwell. They can be very dysphoric. And if anybody's worked with patients with opioid use disorder, you can know that they don't feel quite right even after the acute symptoms of withdrawal are over. They can have this period where their system is really still not properly calibrated. And this leads to things that go on well beyond the period of withdrawal is over. And this is why we use medications, to try and treat this state to make people feel more normal. Next slide. There are different kinds of medications we use. This is an example of methadone, which actually an opiate. It's an exact fit in this receptor, but it has a very long half-life. So it gives, like, instead of the dramatic peaks and declines with heroin or with fentanyl or OxyContin, it gives a slower, steadier state just because of the long declines. Next slide. This is a schematic of how buprenorphine works. It fits in that receptor, but it doesn't fit exactly right. And so really, it's slightly more likely to bind receptors are in the active state versus the inactive state. So it's going to give some stimulation, but it's not going to give complete stimulation, because some of the inactive receptors are going to be bound by buprenorphine, and they're going to kind of be shut down. Other receptors will be bound in their open state and will be held open. Next slide. And then finally, this is naltrexone, which is also an effective medication to treat opioid use disorder. And basically here that's an antagonist. So it binds in the receptor, but it shuts the cells down completely. But the evidence is really quite good that this is an effective treatment for opioid use disorder. Next slide.
Sharon, I have one question if you want right now. That is there
Sure.
any research regarding the effectiveness of buprenorphine versus methadone in youth? What about for adults? And then it says, anecdotally, I've seen individuals do quite well on bup while others struggle on bup and have far better results once they switch to methadone.
Yeah, so that's an excellent question. There's a ton of research on methadone, and it's known to be really a very effective treatment. The problem with it is that can only get methadone at a certified methadone clinic, can't use it in general medical settings. And by law, very few adolescents under the age of 18 will have access to methadone because it's in most cases prohibited to people under age 18. So there's not a lot of research on methadone in youth. Buprenorphine, however, there are a small handful, like 3 studies, all of which show that buprenorphine looks to be effective for treating opioid withdrawal. And much of the premise of treating youth with buprenorphine or people under age 18 really comes from the adult literature, right, which has shown that it's nearly as effective as methadone. So the 3 promising studies we have, combined with extensive adult literature, has led the American Academy of Pediatrics to with this statement recommending medication-assisted treatment, what we used to call medication-assisted treatment, for adolescents with opioid use disorders. Next slide. But there is a problem, and that is that was hinted at before, almost impossible for youth to get this treatment. So out of the 750,000 prescribers in the United States, all of whom can prescribe OxyContin or other opioids and addictive medications. Next slide. Only when this slide was made, only 37,000 of them or so were trained to prescribe buprenorphine, favored to prescribe buprenorphine, and only half of them actually do, and only 1% are pediatricians or serve youth in general. So there are really very, very limited number of folks who specialize in pediatrics, adolescent medicine, or even med peds or family medicine, who are prescribing to young people and who really have solid body of knowledge to work with this age group. Next slide. So I'm glad you're here. And if you're a prescriber and you're interested in having buprenorphine, that you need to take a waiver course. There's specifically one for pediatricians and family physicians that's available through the American Academy of Addiction Psychiatry, and the link is there. Anybody who can prescribe can actually, well, I should say any MD prescriber can take this course, but nurse practitioners and physicians can take this course with a little supplemental training in 8 hours and become waiver to prescribe buprenorphine. And if folks on this call are not waivered, I would strongly encourage them to do so. Next slide. And then finally, I just want to add a plug for addiction medicine training. So about 3 or 4 years ago, addiction medicine was recognized as an accredited specialty by the American College of Graduate Medical Education. Since then, the field has developed 70 residency training programs throughout the country. This is where people who have completed any residency, who are MDs who've completed residency training, can get an additional 1 year of clinical training to specialized in working with this population. And just a little plug, at Boston Children's Hospital, we have the only program in the country that focuses on treating youth. And so we have a pediatric addiction medicine training program that is open and recruiting. So if you know folks really interested in working with this age group, who are interested in maybe doing a year of training in addiction medicine, please do send them our way. We would love to have the opportunity to train lots of people who want to go out and do this work. And with that, I think that is my last slide. So I will thank you for your attention and end there.
Thanks, Sharon.
Thank you, Sharon. We're so pleased to have her joining us. So we've had a bit of a deep dive into kind of why buprenorphine is being discussed today and some of the barriers to youth getting appropriate treatment. And I actually see a question here that will fit well with our next segment, which is a bit of a legal Q&A with Dr. Brian Hurley, who is the Director of Addiction Medicine in Los Angeles County for the Department of Health Services. So let's see, maybe we'll stop sharing our screen because Dr. Hurley and I, we're gonna do a bit of a Q&A. Let's see. Hi, Dr. Hurley, welcome. Thank you for coming.
Hey, thanks for having me. I'm thrilled to be here and to meet everybody. I see some familiar faces, so it's good to see everybody.
Wonderful. So actually, you know, as we're doing kind of a legal Q&A, the question that just popped up from one of our participants is, what about the issue of consent if a patient is under 18?
So there's no specific, like medication-specific consent for buprenorphine independent of like the medical care we'd usually provide. So as long as there's informed consent for sort of the range of medications being offered. So if the question is, what do I do if there's an adolescent who's under the age of 18, who let's for the sake of argument assume is not an emancipated minor, right? Because emancipated minors are can be their own guardian. If the question is, well, you know, do you have to involve the parents? I think the framework for buprenorphine and like, can you provide medical care that the parents might not be aware of, would be similar to, you know, can you offer other types of medications that the parents might not be aware of? I think of like oral contraceptives as being like one example of where an adolescent might want a medical treatment where the parents are aware. And I should admit, I'm not a pediatrician. And so I don't, in my routine practice, have a lot of real world experience to share. But what I do think is always reasonable is you sort of document the risks and benefits and alternatives. I think that from a medical legal perspective, you can, one of the things about buprenorphine, and if you're going to use it for opioid use disorder, is it has tremendous effects on mortality and treatment retention, right? So if you're going to treat over the objection of, or potentially over the unreadiness of a parent to sort of consent on behalf of the child, because parents have authority to sort of consent or not consent on behalf of their child, you would have to document that the risks of not obtaining that consent are outweighed by the benefits. And otherwise, you do have to obtain consent, right? Like that's inherent. You have to obtain consent. So if you're going to not, you would have to have a very clear sort of documentation about why the circumstances were such that you weren't going to obtain consent from the family. The other thing I would suggest is I would just wonder about the mechanics. Like, how is it that a teenager would be able to like go to the pharmacy, pick up the medication, start taking the medication, and do all of this without their parents' involvement? Like that, in my mind, sort of, I would probably spend a lot of my time negotiating with the teen over wanting to educate the family to make sure the entire family system was being aware of the treatment rather than treating over the parents' objection. So that's what I would say is like, what in that circumstances, work with the teen, involve the family to the extent possible. And I would only treat over the sort of parents not knowing or objection if there was a compelling reason to do so. I'm thinking like, I would give, if there was a teen who, I was thinking was at significant risk of overdose, even if the parent wasn't aware, I would still give them naloxone, for example, right? A life-saving rescue medication. That to me is medical legally defensible, right? Because I think no one wants the kid to die, right? Like I think we can all sort of agree on that. But whether I'm going to treat with an ongoing maintenance medication, I don't think I would be able to do that for very long without the parents' consent, and that's what I would try to get. But I'm curious, you know, that's I recognize I've jumped into the middle of a conversation that you've all already been having. And so I don't want to, my kind of off the cuff impression to override what other people think. So I'm curious as to if there's any sort of countervailing opinion.
Yeah, no, that was a really rich discussion. And I think the question arises around psychotherapeutics, and is buprenorphine considered a psychotherapeutic? I know, so Dr. Tajani, you know, as a child and adolescent psychiatrist, you're probably often put in situations where you have to make these decisions about psychotherapeutics. So do you have thoughts on this, or?
Yeah. So when it comes to a psychotropic, which is essentially any medication you use to treat a psychiatric illness, you do actually need parental consent to prescribe a medication in a minor patient. So minors can consent for their own psychiatric treatment, including psychotherapy. But if part of that treatment is going to involve a medication, you do need to contact the parent to get their consent. And my understanding is buprenorphine falls into that category.
And it's interesting because Dr. Hurley, it's interesting that you brought up naloxone, because I really feel like naloxone is in this weird gray area, because I've certainly prescribed it without parental consent because I really didn't want the kid to die.
You can dispense it without a prescription. You know what I mean? I mean, it's legal in the state to be dispensed under a standing order, right?
It is. And when the kid showed up at the pharmacy, they said, I won't give it to you because you're under 18. So
wow.
There's some interesting realities that come to the mechanics of kids actually getting their medication. So it's a really interesting topic. So the next set of questions that I want to ask you, Dr. Hurley, really goes to talk about buprenorphine in various other treatment settings, because the case that we discussed at the beginning of our talk was about a minor who is being successfully treated with buprenorphine, but needs a higher level of care for other and escalating substance use. And many other treatment facilities were under the impression that special licensing is needed in order to treat a patient on buprenorphine. So I'd like to kind of break it down. So first of all, what if you're a hospitalist and a patient is admitted and they're getting buprenorphine and you don't have a waiver to prescribe this, but you're treating the patient in the hospital? What's the loss?
Great. This is a great question. Is it okay if I post some links in the chat? That way there's some references. So if anyone wants to sort of check my receipts here, let me, there's 4 key links to a set of regulations that sort of speak to this. And I have one of them. All right, so those are the 4 links that I put in. And then there is a particular part of Title 21 of CFR, the Code of Federal Regulations, and it's Part 1306. So if it's okay, can I share my screen for a second? It's on a slide, but it sort of gives you an idea of kind of what we're looking at. And I'll try to make this bigger because fortunately, the font on the internet does not always work with me. All right, here we go. So this is the Code of Federal Regulations. And so it has to do with administering or dispensing narcotic drugs. The whole advent of Data 2000 is that you can, if with an X-waivered provider, so it's a physician, an advanced practice nurse, or a physician assistant, is able to prescribe buprenorphine to be taken outside of an OTP. So all of the regulatory framework around Data 2000 is associated with the prescriber, not the setting. And in fact, the whole idea is that you can prescribe in any setting of care: emergency rooms, hospitals, street medicine programs, residential addiction treatment programs. That is, the medication could be administered and taken by the patient in really any setting, and that the responsibility of managing the medication is on the prescriber, not on the setting. But my favorite line from Part 1306 of Title 21 of the Code of Federal Regulations is 1306.07 subsection B. Sorry for the legalese, but nothing in this section shall prohibit a physician who is not registered to conduct narcotic treatment program from administering narcotic drugs to a person from the purposes of relieving acute withdrawal symptoms while necessary, while arrangements are being made for referral to treatment. And Section C, which is this section is not intended to impose any limitations on a physician or authorized hospital staff to administer or dispense narcotic drugs in a hospital, to maintain or detoxify a person as an incidental adjunct to medical or surgical treatment for conditions other than addiction, or to administer or dispense narcotic drugs to a person with intractable pain in which no relief or cure is possible and none has been found after reasonable efforts. So this section C basically says, if you're an inpatient, let's say pediatric hospitalist, and a patient is experiencing opiate withdrawal, or you think has opioid use disorder, there is no limitation on being able to initiate a medication like buprenorphine or even methadone, in fact, to that patient while they're in the inpatient setting. There's no OTP license required. There is no X waiver required. So when the patient's inpatient, and as long as the admitting diagnosis is not opioid use disorder, right? If the admitting diagnosis is injury, pneumonia, anything that's not an opioid use disorder, then the Code of Federal Regulations specifically say it's legal to treat that patient with a narcotic medication like buprenorphine or methadone that's necessary to maintain or detoxify that person, as long as it's incidental to a medical or surgical treatment that's other than addiction. So that's the inpatient framework. So, and this includes the ER. So one of the things I've been training, I work for the LA County Department of Health Services. I've been training our hospitalists and our emergency physicians is like, don't hesitate to order, you can't prescribe it, but you can order it to be administered in the facility. If the patient's experiencing opiate withdrawal, you can initiate a medication for opioid use disorder to alleviate that withdrawal. It's when you then, that hospitalist writes a prescription that patient or that patient's parent would take to a community pharmacy. It's at that point that you have to have the X waiver, you have to have the DATA 2000 waiver, because the outpatient pharmacy can't fill that prescription for the patient to take to wherever setting they're going to next, home or otherwise, without an X waiver.
Dr. Hurley, what about psychiatric hospitals? Is it the same or different?
So this particularly says in a hospital.
Okay.
In a hospital. Now, there's a separate set of laws, sorry I didn't include the link, but there was in California, there was an all facilities letter that basically said, and I'll look it up here in a minute, but the AFL said that inpatient psychiatric hospitals, medical surgical hospitals, essentially any inpatient facilities, any hospitals in the state of California are permitted to maintain or detoxify there we go. There's the AFL. Thank you for pulling it up. Any general acute care hospital, acute psychiatric hospital, or chemical dependency recovery hospital can treat addiction to a narcotic drug, including MAT protocols, under their respective licenses. So it's legal to do for inpatient psychiatric, it's legal to do for general acute care hospitals, and it's legal to do for chemical dependency recovery hospitals. I've asked the state, what about psychiatric residences? Because it would be great for an AFL to also include and psychiatric residentials. I'll say there is absolutely nothing in law that says general psychiatric residentials cannot, administer buprenorphine that's been prescribed by an X waiver. But I know that there's some residentials that say, but it doesn't say we can. I'm like, right, but there's nothing in the law that says you can't, right? Like there's no regulation that requires psychiatric recovery residents or an addiction recovery residents from as long as it's prescribed by an X waiver provider, from the patient having access to their prescribed medication while they're in residential treatment. And so this has been an active area discussion and policy with the state. I will say there's no law federally or statewide that requires adolescent or even adult psychiatric residentials or addiction treatment residentials to have any other licensing in order to have the patient have access to their medication. There is something for drug Medi-Cal. The drug Medi-Cal, if you want to get paid by drug Medi-Cal to do MAT services at your residential, there is an additional certification called Incidental Medical Services. It's an application. It's pretty easy to fill out that basically says you're now authorized, you're certified to provide MAT services at residential. But I think like most residentials, we don't, it's sort of illogical that we would give patients access to their medical meds, right? Like insulin or whatever, whatever other medical meds that they might need. But we wouldn't permit access to buprenorphine. So there's no separate requirement, particularly opiate treatment requirement required for residentials to make the patient's medication available to them, particularly buprenorphine.
Thank you. And I have a question here from Dr. El-Manshawi, who asks, if the admitting diagnosis at the psychiatric facility is opioid use disorder as well as concurrent mood disorder, does Section C still apply?
Yeah, Section C would apply depending on the primary diagnosis. So it doesn't depend, if there is a secondary diagnosis, as long as the admitting diagnosis is not opioid use disorder, then Section C applies. So if it's unspecified mood disorder, that's a primary mental health diagnosis, and Section C would apply. So for most pediatric inpatient units, you're not usually admitting to inpatient psychiatric treatment for OUD. You're admitting for primary mood. You're admitting for sort of primary mental health. In fact, I don't think you can get paid by DMH, right, by our county, especially mental health, to admit anybody for OUD in an inpatient mental health facility. So as long as the primary diagnosis, as long as the main reason they're there is not OUD, then Section C applies. If it is OUD, then the assumption is you're a detox, right? You're a licensed detox facility, right? Because if the admitting diagnosis is OUD, then the assumption is you must be a primary detox facility and you would do it under your OUD licensure. So Section C would not apply to detoxes, but it does apply to any other inpatient, so psychiatric, inpatient acute med surg or chemical dependency hospitals where the admitting diagnosis is not OUD. Section C applies.
One last question before we move on to our next speaker. You mentioned detox facilities. Can do general hospitals, so for example, I work at Benioff Children's Hospital. Say we have a kid in the ER who is in opioid withdrawal, and that's really the primary diagnosis. Do those hospitals need any kind of special certification to say that they can provide detox, or can they just do it?
Yeah, they can absolutely do it. Typically, the admitting diagnosis is, like tachycardia, just, like malaise, right? I mean, there's a bunch of stuff that you can sort of put in that becomes the admitting diagnosis. It's generally not OUD. You don't need a special license to do an opioid detox, as part of medical treatment. Generally speaking, so even if it's opioid withdrawal syndrome, that's the main thing that you're treating. The admitting, there's a fair amount of flexibility in what the admitting doses might be with opioid withdrawal syndrome, and you can absolutely still admit for that. So you don't need a separate license. And in fact, all facilities that are even emphasize that. You can do that as part of your acute care license. You don't need a separate detox license or AOD or alcohol or other drug treatment license in order to be able to detox a patient when they're admitted to your medical surgical facility. We don't usually, it's not common for the primary diagnosis to be opioid withdrawal syndrome, but it's still possible, and you can still do it under your general medical license. It's where, when you get to inpatient psychiatric, that's where the primary diagnosis really better be mental health, because otherwise generally the payer won't pay for inpatient psychiatric treatment if it's the primary diagnosis isn't mental health.
That makes sense. Well, thank you so much. I think this speaks to a lot of the complexity around this issue. And I think why there's a lot of still stigma and fear around working with patients who are who are getting medications for opioid use disorder. So I appreciate your insights. And thank you for joining us.
I appreciate you having me on, and very grateful to, I don't know if it's to Johnny or to Hani, but to my psychiatrist colleague, I appreciate your input. Thank you.
Thank you. So next we'll move on to Leslie Green, who is a social worker at Boston Children's ASAP program, which is their adolescent substance use treatment program. So off to you, Leslie.
Thank you. All right. Well, my job today is I have the honor of interviewing one of our former patients' mothers who's joined us today. So Carol, if you could present yourself. She's been hiding behind a pseudonym. Carol,
I'm here. Yeah, Carol Allen. I live in Massachusetts. I live in Easton, Massachusetts. And my daughter entered the Children's Hospital program shortly after her 18th birthday.
Yeah. So you were with us just for a couple of years, and it was an honor for me to work with you for sure. Can you give us a little bit, just a brief history of your daughter Cora's, her use history as well as treatment progress? Yeah.
Sure. She had, a co-depression, had it since she was about 13. She manifested with some mild marijuana use at first, went on to become anorexic, went on to cut, was introduced to Percocets when she was 16. They were not from my home. We did not have them here. And then the summer before she turned 18, she went to a concert with friends, and she was struggling trying to find Percocet illegally, and it was becoming very costly. And this wonderful friend of hers said, I have something that you can try that'll give you the same high, but it won't cost so much. And that was our first experience and the beginning of getting down into the rabbit hole of injectable heroin addiction.
Yeah. During that time when she was using opioids and then heroin, opiate, did she experience any overdose, or did you have high concern for overdose for her at that time?
No, because my daughter was in show choir. She was a catcher for the softball team. She played the upright bass in the orchestra. She got really good grades. She worked. She was an extremely high functioning addict and hid it well. We knew something was off, but we couldn't quite put our fingers on it, you know, after room searches and car searches. And then one day, it was just before Thanksgiving that year, she just left her stuff out for me to find.
Okay.
So she definitely knew she was in way beyond what she had imagined.
Mm-hmm. And then you took steps towards getting her into treatment.
Well, she had actually taken the first steps. She had already contacted a drug therapist from High Point, which is an adult actually drug treatment program in the area. She had turned 18 by this time. So she had that typical, I'm in charge of myself, I'm 18. And she left there. She almost died during her detox. There was no medically assisted detox at that facility. And she left that facility with a pamphlet that showed her she needed to go to 90 meetings in 90 days with no backup anything. She saw a therapist a couple times, but you know, by this point, I knew what she looked like when she was using it. It was just such a foreign area for me. I learned a lot of things I never thought I would ever have to learn. But the last time she used, by the time she used the last time, we had already contacted Children's Hospital with our concerns. She went into a bathroom at McDonald's across from Good Samaritan Hospital and shot up for the last time, and then brought herself to the emergency room, where I sat with her all night and watched her come down off of this drug, scratching her chest and her face and bleeding. And it was an awful thing to see, but it was necessary for me to be there. And in the morning, they shipped her off to the Gosnold.
Oh, I know that guy.
I think if somebody just needs to mute. So she ended up in a residentially based treatment program, and I believe she Suboxone there for the first time.
Yes, she did for the first time. So her detox was a lot better at that facility. And the day that she was discharged, I had already made arrangements with Children's that we picked her up in Falmouth and drove her to Children's Hospital for her intake.
Yeah, and then we entered the scene. So what overall has been your and her experience with Suboxone?
I was an educator for 34 years. I mean, it's always, to me, I've dealt with thousands and thousands of children. And I know this is going to sound odd, but I kind of associated Suboxone with an ADHD medication. It took away the cravings for her enough so that she could actually focus on recovery instead of being in a constant state of need for more opiates. She was pretty foggy by the time, you know, we had gotten into Children's Hospital, but the cravings were gone, so that she was able to finish school that year. We kept her home and had tutors. We hired people to stay with her at the house so we could go to work. But I think that Suboxone really, not sure if it prevented her from, you know, going out and seeking other drugs, but it really took the edge off of her so that she could focus on the other things that we were working on in treatment at Children's.
Yeah. And how easy or difficult was it for you to administer it or for her to take it? Were there any difficulties around that, or was that the process pretty easy?
The process was pretty easy. Dr. Levy was pretty upfront with us, and as Children's Hospital always treats this as an illness. We were all able to assimilate into that mindset that this was an illness. And everybody has to take, if you have a chronic illness, you take a medication to help you through it. So we were all on board with that. She was on board with it because she just knew she was in way over her head. She had drug dealers coming to the house, and she got beat up outside of work, and we had to sell her car. And she had a yellow Volkswagen, which was pretty distinctive amongst drug dealers. But she didn't have any issues. I held the medication. She used the under the tongue strips, and I administered it every day, and I sat with her and made sure that it was dissolved before we went on with our day. She was a pretty amazing patient. She actually, after about 6 months, decided that she felt like she was strong enough to start weaning off Suboxone. And I know Children's usually recommends about a year. And,
I remember having conversations with you about
she was pretty heavily invested in other parts of her treatment as well. So I knew recovery was her goal. So she wasn't addicted. She wasn't a long-term addict, and I'm not sure if that had any bearing on not having to be on it for a year. But Cora's pretty strong-willed, and she just fought through this with everything she had. It'll be 9 years in January, and she still attends meetings. She has her own group. She sponsors. She ran her own halfway house for a while. At her house, she would take in her friends that were struggling, and she's still very, very active in the recovery community. And she says she knows she has to do that.
Yeah. So Carol, one more question for you regarding her mental health that you described that she was experiencing. Probably, it sounds like predated use.
Yes.
How would you say the Suboxone was helpful in her being able to maintain participation in mental health treatment?
I think it was what caused her to be able to maintain treatment. She described it to me as though every second of every day you are craving this drug. There's not a moment that goes by that you're not thinking about heroin and wondering where you're going to get it. And the Suboxone took that aspect away. So she could sit with Shannon, and she could sit with the psychiatrist and actually have meaningful discussions without sitting there the entire time, craving this medication. So I think it was very, very helpful in guiding her through the journey. I would have liked her to stay on it a little bit longer, but it all worked out. It all worked out. It could have been worse, but it all worked out.
Carol, thank you so much for your time. And
you're welcome.
Kudos to you, because you were also a crucial piece in her recovery process. And
kudos to Children's Hospital, because the curriculum that the parents had to follow was pretty strict, and it was treated as a family illness, and the treatment was based on family. And I was lucky enough to have a family, both nuclear and extended, that participated willingly in all of the steps for her recovery.
Yeah, thank you so much for joining us and
Thank
sharing
you
your
for
story.
Inviting me.
And she's also being modest, and she's also very active in speaking. This was not her first gig at speaking. She was on NBC News with Cora, et cetera. So Carol's really been out there doing her thing. So thank you for your time.
You're welcome. Thank you for inviting me.
Yeah. Okay, so my job is to now pass this on to Dr. Tajani, who is going to, I'm also sharing my screen and getting us back to the presentation. She is going to share with us about opioid use disorders and co-occurring psychiatric disorders. So thank you, Dr. Tajani.
All right. Thanks, Leslie. And thank you, Carol, for sharing with us that really moving and inspiring story of your and your daughter's personal experience. I think all of us in healthcare can benefit from hearing stories like that more often. And today I'm going to be talking about the role that co-occurring psychiatric disorders play in the development and treatment of opioid use disorder, and some of what I'll be touching upon you've already highlighted for us with your daughter's experience. So the reason that this is such an important topic is that it's extremely common, as you can see here from this bar graph, showing the percentage of youth who present for SUD treatment with other psychiatric disorders is that the vast majority, 80% or more of young people with an SUD have at least one co-occurring psychiatric disorder. And in some clinical samples, the numbers are more like 90%. And half or more actually have 3 or more co-occurring psychiatric disorders, the most common ones being major depressive disorder, PTSD, conduct disorder, and ADHD. So this is really the rule, not the exception. I just want to drive home the point that if you work with young people, if you work with teens and young adults, and really older adults too, you are going to be seeing patients who have co-occurring disorders. Psychiatric disorders and substance use disorders have the highest rates or past year prevalence in young adults. That is the developmental period where we see the highest percentage of both of these disorders. So it's really the group we need to target most readily. So if a patient comes into your office with a psychiatric diagnosis, the evidence tells us that they are at higher risk of one day having an opioid use disorder. And if they come in needing a opioid prescription for pain or after a surgical procedure, they have a psychiatric diagnosis, they're at 2 or 3 times the risk of developing opioid misuse, prolonged use of that prescription opioid or other opioids, and eventually possibly opioid use disorder. If you work in a setting, thanks. If you work in a setting where you're mostly seeing patients who have a substance use diagnosis, you are also seeing patients with co-occurring disorders because, as I touched upon in the last slide, there's a high prevalence of psychiatric disorders in this population. And also there is a higher likelihood that their psychiatric disorder, particularly their depressive disorder, is not going to respond as well to treatment as patients who have MDD without an SUD. And then most specifically for patients who have opioid use disorder, they tend to have greater severity of psychiatric disorders than people with other SUDs. Greater severity specifically of MDD is what we see in this population. So looking in a little more detail at the group of young people who either have an OUD or an OUD and a mood disorder, what we find is that youth with OUD commonly have suicidality, either suicidal thoughts, self-injurious behavior, or suicide attempts. They also have higher rates of other risky behaviors, such as risky sexual behaviors, and they have a poor long-term functional prognosis, especially if they don't receive treatment. So in addition to worse SUD and psychiatric outcomes, they have poor academic, social, and other functional outcomes, and treatment can help to improve that prognosis. Youth who have mood disorders, specifically in OUD, are at very high risk of overdose, opioid overdose, mood disorder, especially one that involves emotional dysregulation, puts a patient at 9 times the risk of having an opioid overdose. It's actually the second most significant risk factor for opioid overdose, just behind injection drug use. Depressive symptoms predict pre-treatment opioid use disorder or opioid use frequency. So patients who have depression use opioids more frequently. And the depressive symptoms often predate the initiation of opioid use and the opioid use disorder, as we heard from Carol. Just briefly, I want to talk about the biological reasons for this. I know Dr. Levy already spoke so eloquently about some of this, namely the part about the adolescent brain having a more robustly functioning reward system than a executive functioning system. So the reward pathway develops more fully before the executive functioning pathway. So young people have a high desire for and response to rewarding stimuli, but they don't have quite as robustly functioning cognitive control or behavioral control. So that discrepancy puts them at greater risk of substance use. Now, there's also a couple other relevant developmentally normal biological differences that contribute both to SUD and also to the high risk of depression for this age group. And these are the fact that youth have a stronger stress response. Their bodies release more cortisol in response to acute or even ongoing chronic stress, and it takes longer for their cortisol levels to reset to normal after a stressor. So they're, in higher higher states of stress when there are stressful things happening. And we know stress is very strongly associated with drug use and drug persistence. In addition, young people's amygdalas fire more readily, especially when they see neutral faces or fearful faces compared to adults. So young people are more likely to interpret a neutral face as negative, as either angry or scared, disapproving. And when they see fearful faces, they have especially strong emotional response to that due to the amygdala firing so readily. And again, this is all normal. It's evolutionarily adaptive, as Dr. Levy talked about. Adolescence is the time generally where humans need to become more independent. They need to learn new skills, how to survive on their own a bit more in the world. But kind of by an accident of nature, drug use can kind of co-opt and take advantage of these differences and make it harder for young people to stop using once they've started and more likely to start to begin with. And interestingly, but probably not surprisingly, the domains that I just talked about that are a little different in adolescents compared to adults are exactly the same neurofunctional domains that are implicated in the development and maintenance of addiction. So this graphic is from some really wonderful research from Koob and Quackow that shows the main functional domains that contribute to addiction risk or maintenance are increased negative emotionality, impaired executive functioning, and impaired incentive salience, which is essentially the amount of desire or wanting that is attributed or assigned to a given stimuli. So again, it's normal for all young people to have some vulnerabilities in these domains, but some young people have even higher levels of deficits or vulnerabilities. And as you can kind of see on the bottom here, that's largely due to the presence of certain co-occurring disorders, which result in greater dysfunction in these areas. The good news about those domains and sort of understanding them is that they give us targets for prevention and treatment. And so here I've outlined kind of a way to conceptualize the mechanisms by which various addiction or even many psychiatric treatments work. By and large, they do one or many of all four of these things. They improve prefrontal cortex functioning, they reduce the reward pathway salience or attention to drugs, and increase salience or attention to other non-drug stimuli. They kind of stabilize the stress system and enhance anti-stress system firing, and they improve the emotional regulation ability. So here I've summarized the basics of what we know about co-occurring disorders, sort of the nuts and bolts. They are the rule, not the exception. most patients with co-occurring disorders receive suboptimal treatment for both of their disorders. And while the adult research is somewhat mixed regarding how co-occurring psychiatric disorders affect SUD and OUD outcomes, with some studies showing that the presence of a psychiatric disorder leads to worse SUD outcomes, and other studies showing that the presence of certain psychiatric disorders leads to improved SUD outcomes. The youth data is much more clear and overwhelmingly shows that the presence of a psychiatric disorder or the history of a psychiatric disorder in a young person who has an SUD, including OUD, results in better OUD outcomes, namely less attrition from treatment, so better retention, staying in treatment, engaging in treatment, and less opioid use with evidence-based treatment. And this image on the right here just kind of explains why and shows how interconnected all of these things are. So here I've just put a summary of the findings from a paper that was recently published that looked at the impact of a current or previous MDD diagnosis on outcomes, OUD outcomes for patients who were receiving buprenorphine. This is actually an adult study. What this study found is that a current or previous MDD diagnosis was strongly associated with better OUD outcomes, which was defined as less opioid use at study end. Patients who had MDD actually had greater motivation and engagement in treatment, namely through more participation in mutual health groups, and that it was this greater treatment engagement that was mediated by the MDD diagnosis or history that had a causal association with the improved OUD outcomes. So even though the depressive symptoms on average improved for patients in the study, the reduction in the depressive symptoms, that alone was not what led to the better OUD outcome. It was the fact that patients were more involved in their treatment, more engaged and motivated. And they actually found that coming into treatment with a goal of opioid abstinence had no impact on the OUD outcome. And I point this out because, as all of us who see young people know, rarely do youth, especially adolescents, who are brought into treatment, and I say brought in because often they're brought in by their parents, they're often not coming in wanting, or at least not enthusiastically wanting, SUD treatment. And you don't need to enthusiastically want it to benefit from treatment. And actually, if you have a co-occurring disorder, that can be a route by which we can get patients interested in participating, because most young people will want to feel less depressed or less anxious. So it's kind of important to understand that as a starting point when working with young people who may be kind of resistant or early in the stages of change. So here I've summarized the small but growing body of literature looking at the impact of co-occurring psychiatric disorders on youth specifically and their treatment outcomes. And actually the outcomes here are specifically in regard to opioid use disorder. So there have been a number of studies that have now found that youth who have OUD, who come in for treatment for their OUD and receive the evidence-based treatment, buprenorphine, that those who have a higher severity of depressive symptoms and higher distress levels at intake actually have better OUD outcomes. Patients who are on ancillary treatments and medications for psychiatric disorders or symptoms also have better OUD outcomes. And there's one small study in emerging adults that was done in Europe that found young adults who had a heroin use disorder who received medication for addiction treatment along with psychosocial supports, that in addition to having better OUD outcomes at the end of the study, they also had better psychological well-being. And these were all patients that had a history of heroin dependence. The anxiety and depressive symptom domains improved the most, with 1/3 of the patients normalizing from their baseline elevated scores in those areas. So really discontinuing buprenorphine is the only significant factor that has been associated with worse youth OUD outcomes. So having a psychiatric disorder, current or previous, does not mean that a patient is not going to do well on buprenorphine. Another thing to think about, especially for folks who are therapists or who provide psychosocial services, is that we have data showing that youth who receive buprenorphine for their opioid use disorder, that they not only improve in their opioid use disorder outcome with buprenorphine treatment, but that they do just as well as older adults. So this is from a study, it was a fairly small one, but just recently published, that took a group of patients who were on a wait list for more comprehensive opioid use disorder treatment involving psychosocial services, psychotherapy, and support groups. And while they were on this wait list for 3 months, they received buprenorphine and bi-monthly clinic visits. That was it. In the emerging adults, despite coming in with higher levels of injection drug use, greater legal and psychiatric severity, their outcomes at the end of the study were just as good as the older adults, and they actually had greater decreases in the anxiety and depressive scores than the older adult group. And the psychiatric disorder severity at intake was not at all associated with their outcomes. I know many of the folks who presented before me talked about the issue of retention. It's hard to keep people of all ages in psychiatric and SUD treatment. Young people have the highest rates of attrition in general, but youth who have co-occurring disorders have better rates of retention than youth who do not have co-occurring disorders. Also, we know buprenorphine improves retention in OUD treatment for people of all ages. And pretreatment use of medication for pain, sleep, or psychiatric disorders is associated with better retention. And these graphs here from a recent study in the journal Pediatrics, and Dr. Levy was one of the co-authors on this study. And this study looked at how many youth received treatment for their opioid use disorder after receiving a diagnosis, and what type of treatment did they receive. And they followed them for 3 months. So a little more than half of these patients received behavioral health services only, so no medications for addiction treatment. A quarter received both. And what they found is that the young people who received both behavioral health and medication, and in this study it was buprenorphine, naltrexone, or methadone, it could be any of the three, they remained more engaged in both their addiction treatment and their mental health treatment. So it helps with both. The medication really makes a difference in keeping people in treatment. And this is just really to highlight the point that medication for addiction and psychosocial treatment for addiction, they're complementary. They are not opposed to each other in any way. They support the same goals. They largely kind of target the same pathways really in the mind through different mechanisms. And while there really are no studies yet looking at the role of adding psychotherapy or other psychosocial services to youth who have opioid use disorder who are receiving buprenorphine, there is adult data that tells us that most patients will do better with the addition of a psychosocial service. So optimally, we want patients receiving medication and other services. And then my last slide, there's one more after this, but it's just sort of a summary. So I just wanted to point out that there is some data that psychiatric comorbidity decreases the likelihood of clients dropping out of treatment. I mentioned that previously, but we've also found that patients who have co-occurring psychiatric disorders, they're more likely to be discharged from their treatment program before they want to be. And this actually is a big part of what lowers their likelihood of receiving or continuing to receive medication for opioid use disorder. And to begin with, very few patients even have medication for opioid use disorder in their treatment plan, at least not in residential facilities. So this we can skip over. It's just showing how rare it is for people to get integrated treatment. We need more of that. We can do better. And if we all take an interest in working with this population, there's a lot we can do to lower the opioid overdose death rate and improve people's long-term functional prognosis.
Thank you so much, Dr. Tajani. You're always like an encyclopedia every time I speak with you, so we really appreciate it. So, to wrap up, I want to be respectful of everybody's time. I want to get down to the nitty gritty of how can you get started with buprenorphine prescribing so you can help this very vulnerable population. Next slide. So I was going to go over a little bit about the history of the DEA X waiver, but I'll just sum it up to say that in order to be able to prescribe buprenorphine on an outpatient basis, you do need to get some special training. Again, if you're in a hospital, you're exempt, so you can prescribe it. This is for outpatient only. So next slide. And basically here are the list of qualified practitioners. So it's any physician as well as advanced practice providers can prescribe buprenorphine. Physicians must complete 8 hours of approved training and advanced practitioners must complete 24 hours. There's a lot of controversy of whether the waiver is, whether it should be taken away, because we've seen in countries that have deregulated buprenorphine, there's actually been increased rates of prescribing and decreases in overall opioid overdose death rates. So there's a large contingent of addiction medicine providers who are petitioning the government to get rid of the X waiver. Next slide. And basically because it can cause a lot of barriers to getting patients the treatment they need. Next slide. So this is to highlight that we are hosting a youth-specific DEA X waiver training next week, October 16th. It will be taught by our very own Dr. Tajani, as well as one of her colleagues, Dr. Jeffrey DeVito. This is the half-day virtual course, and it will be accompanied with the 4 hours of online training. So if you're a physician, that completes the 8 hours that is required for you to get your DEA X waiver. And I included a QR code if you'd like to register for this course and get trained. Scan this QR code using your camera and you can register, and we would love to have you join us for this very, very, very important training. And that wraps it up. So I just want to thank everybody for their time, and please send us your questions. Michelle will send a follow-up email to everyone who registered with contact information, so you can reach out to any of us with outstanding questions. Okay.
I'll just say this may be part 1, right? So if you have a lot of questions, we can try to do this again to address those questions. So yeah, thank you
again, everybody. Bye.